Topic. Since most of us are general practitioners and our lecturer is neurologist specialized, always pay attention during an examination to differentiate orthopedic patient from neurologic patient. This is very important to not be confused during.
Yeah, that's a good point. And again, that will be part of my next talk. Yeah, because
Sorry.
I believe that's very important. I mean, for me as a neurologist, it's a little bit easier because most patients that come to me are already selected. However, we have to make sure at the beginning is that an orthopedic disease, sometimes it can even be a cardiological disease, it may look like a neurological disease. So to make that difference at the beginning, that's very important. And I hope that, again, I will address that now. Okay. Once we have done our neurological examination, the whole reason why we did that is to localize the problem to a certain area of the nervous system, because unfortunately that's not the way the patient come in. They don't tell you what the problem is. So we have to narrow it down to a certain area of the nervous system. And to highlight the importance, I would like to introduce you to Beautiful, which is Beautiful, 3-year-old French bulldog that was referred to us with that X-ray, and you can already see that the significant malformation of the thoracic spine. And those clinicians even did a myelography, so they did inject contrast in the subarachnoid space. That white stuff here is contrast, and you can see how the spinal cord is narrowed by that malformation. Probably it's about half the diameter in the area of the malformation in comparison to the normal area. And we were asked to, if possible, to perform a surgery to correct that. It's quite common, yeah. If at all, it's a very difficult surgery, yeah, if we do that at all. More importantly is something completely different. When we got that referred, that the patient had a real limb paresis for 2 weeks duration. At that time, our surgeons were on duty. So in our hospital, neurologists do most of the neurosurgery, but sometimes surgeons do. And it was the week where surgeons were responsible, and I had to stop those surgeons from doing the surgery. That's the other question, what surgery? To answer that question right away, what we believe nowadays is probably most helpful is not removing the narrowing, it's probably more helpful to stabilize the spine in that area. But nobody ever actually had done an examination on that patient. Nobody had actually thought about that patient. And it turned out that this dog had a real limb paresis, but this dog had a reduced proprioception in all 4 limbs. Not only in the rear limbs, but in the front limbs as well. A lesion in that area, in the thoracic spine, cannot at all explain why that patient had reduced conscious proprioception in the front limbs. So we said there must be a problem somewhere in the cervical spine. And we did an MRI actually, that's our old scanner, that's why the image is not as good, but here's the brain, here's the cervical spine. For those of you who don't see MRIs on a regular basis, those white dots here, that's the nucleus pulposus of the disc, that's the way it's supposed to look like. And the spinal cord, that's that elongated area here. And the normal appearance of the spinal cord is this gray here. What is abnormal in that image is the white here and is the white here. This dog has significant edema in several areas of the cervical spine. And that might be the most important problem right now. The message here is not that you need an MRI in all cases. The message here is that you have to perform a neurological examination and determine where do I look for the problem. If anybody would have done a neuro examination in that dog before, we would have recognized that the malformation here, as bad as it is, might not be at least not be the only problem of that dog. By the way, it's not this dog, but I'm not sure if you have heard about the cop angle. There was a study performed 5 years, in the meantime 6 years ago, that established the so-called cop angle. So if you have a malformed spine, you take the last intervertebral disc space that appears to be normal in front of the lesion, and you take the first disc space, it's probably not the correct drawing, but you take the first disc space behind the lesion, and you measure the angle between those two. And if that cop angle is larger than 35 degrees, it's probably a relevant lesion. Or to turn it around, many patients with a cop angle below 35 degrees do not have neurological problems, even though that may look like a catastrophe. And there is another paper saying that only 10% of French bulldogs with compressive malformation have neurological deficits. So we take those images, we see that looks really bad. But if a dog comes in with neurological deficits, you better look for something else before you call that the underlying pathology why the dog is coming in now. So it looks bad, but it may not be the reason. I've shown you this image before. Why do we care about all this? Because we have MRI now, and that gives us all the diagnoses. Some people believe that the MRI is a small brother of this one. I'm not sure if we have this TV show here on TV as well. Does that person look familiar to some of you? No. Okay.
That's Star Trek.
Yeah, that's Star Trek, exactly. It's an EMH. This person is an EMH. EMH stands for a doctor, a medical doctor. But it's only a computer program, so it's an emergency hologram. He works as a doctor on a spaceship. And he has this little device here that he puts on a patient, and then he gets a diagnosis. Yeah? And some people believe that the MRI we have right now is the large brother of the device. And we get quite often the question of referring veterinarians, can't you put the patient into the MRI and tell us what's wrong? I usually say I have to do an exam first, and then I determine if I take X-rays, if I do a CT, if I do an MRI, if I do electrodiagnostics, if I take a CSF test, whatever is necessary. But the idea that in times of MRI everything else is not necessary, that's not true. Now we have to select those patients that need MRI, and MRI is very important. Without MRI, I would not be standing here. But it's not the solution of everything. I usually look at my job in the picture of those stairs. In order to get to the top stair to a successful treatment, you have to take all those steps before. If you avoid one of those, or if you're not able to perform one of those, there's no way that you can perform a successful therapy. I mean, you can still take prednisolone, it may help some patients. Yeah? But usually you get not a successful treatment. Neurolocalization. Does that look crazy? You find those images in textbooks, and I hate them. Yeah? They are not helpful at all. Mm-hmm. So I will introduce you to a different way to deal with those patients. The neurosnail. I didn't call it a neurosnail, my student said it looks like a snail, what I will tell you in a few seconds. But the difference is that we follow certain steps in a circle, one after the other. If you have a patient, the first thing we want to determine is, and that's what you said, is that a neurological disease or is that something else? Once we have answered that question with yes, the second question is, can that patient have a lesion in the peripheral nervous system? That's quite different than many other people teach, because the peripheral nervous system, that's somehow neglected, that comes at the end. I usually say, ask yourself first, can that problem be outside brain and spinal cord? If you say no, then the next question is, could the problem be in the head? I intentionally didn't write brain, because we still have the inner ear, the neurologist occupied. Yeah? So could that problem be in the head? If you say no, then the only thing that is left is the spinal cord. And you can see that somehow going around. If you get an answer here, then you stop here. You don't need the other steps. And I believe that's more helpful than those instructions you find in textbook with different divisions, and after 3 steps you don't know it all anymore very well. Now, having said that it's much easier, I have to warn you of the next slide. Please don't give up when you see the next slide. The next slide is the entire summary of my talk about neurolocalization. So if you know what is on the next slide, then you are perfect. What you will recognize on the next slide are still those steps. Okay, everybody ready for it? Please not. I will try to explain. We still have the question at the beginning. Do we have a neurological lesion? If not, can it be the peripheral nervous system? If it is not there, can it be in the brain? If it is not there, it's in the spinal cord. And we will go through those steps. All that starts with, do we have a patient with a neurological problem? And I have listed here a few things. If you see one of those, then you know you are dealing with a nervous system disease. Seizures. And it does not have to be that you observe those seizures. If the patient does, or the patient doesn't describe it, but the owner, if the owner describes seizures, even if you do your neurological examination, the patient is completely normal. If there were seizures, it's a problem of the nervous system. You do not need anything else. Reduced conscious proprioception. If you perform the conscious proprioception in the correct way, and it's only lost in one limb, you can answer your first question with yes. Paresis, plegia, the same. Circling. Let me say something about circling. There are 2 different ways of circling. There's one way where the patient walks in tight circles. It cannot go straight. Often it's associated with a head tilt. I usually say those are the patients you can take out for a walk, just leave the dog there for 30 minutes and half an hour later you pick it up again because it's still there. Yeah? It cannot go away. It's walking in circles. That's usually a vestibular problem. We'll talk about it, what that means from the anatomy. There's a different way of circling. In patients that can go straight. But whenever they have to make a decision between left and right, they decide for the same side. That's something you only appreciate if you allow the patient to walk around in your exam room for a while. As long as the patient is sitting beside the owner or on your exam table, you will not recognize it. That's usually a forebrain problem. Restless walking with a tendency to the same side. If you see any of those, you know it's a problem of the nervous system. So any single symptoms here, any of those things of the symptoms will allow you to answer the first question with yes. If your answer is no, then you may have to do an orthopedic examination or what else. But if the answer is yes, then you start going through this snail. And the next question, before, I have some nice seizure videos here. Because that's so cool, you have to see it. The question is, do we look at a seizure? In this case, it is straightforward. If you see something like that, if it is a short period of 1 to 2 minutes, the patient has those tonic-clonic phases, and after 1 to 2 minutes it's over, and it needs a few minutes to a few hours to recover, then it's probably a seizure. So that's something we call a no-brainer. not because the cat doesn't have a brain, but it's easy to recognize that those are seizures. And if the owner describes that, or the owner comes in with a video like that, you know it's neurologic disease. However, it can become more difficult. It's a different type of seizures here. This German Shepherd dog is still walking around, as you will see. It just has some twitches. And you have to determine if you are looking at seizures. We have a separate talk about that, but I can already tell you now, if you see something that is there for 1, 2, 3 minutes, and it goes along with significant salivation, it's probably a seizure. The picture changes if the dog does that for hours. Then it may have something in its mouth, it's a foreign body or something. But if it's 1, 2, 3 minutes together with salivation, it's usually a seizure. In cats, it gets more difficult. In cats, seizures can look nearly like everything. Here I have a specific type of seizures, which are frequently seen in cats. That's still before the seizure. I believe it's already the beginning because we already have some dilated pupils. And it may even be that is the only thing you see, but in a moment you will see that it becomes worse. So it's outside of the cage now. So we're not doing anything to the cat. It's just becoming aggressive.
That's just Dubai cats.
Sorry?
That's just Dubai cats.
The owner was an old lady, and she was totally afraid of leaving the room because the cat was protecting the door. Luckily enough, those were only episodes, but mental changes that last for a few minutes can be seizures in cats. If somebody wonders if the reason is this swollen paw, had anybody seen that?
Mm-hmm.
Yeah, okay. That was not the reason of the seizure. Seizures. If you see seizures, neurological disease. If you see nystagmus, we will talk about vestibular disease specific, but if you see nystagmus, meaning a rhythmic eye movement with a slow and a fast pace, it's neurologic disease. So all those little bits of information, one of them would be enough to say yes to the very first question, it's a neurologic disease. Conscious proprioception, we will talk about that, deficits in conscious proprioception. We will skip that. One word about conscious proprioception. I said it's very reliable in order to tell you if you are dealing with a disease of the nervous system. Yes? It's only partially helpful in detecting where in the nervous system the underlying problem is. And the reason is, if I turn around this paw here, the information is going up the peripheral nerve to the spinal cord, and then it's traveling along the spinal cord to the brainstem and to the forebrain, to the opposite side, to the sensory cortex, from there to the motor cortex, and then the response is coming back the entire way, and the paw is placed in the correct position. And we have tested more or less the entire entire nervous system. So yes, it's great because we have a test that is testing more or less the entire nervous system to say there is neurologic disease, but it's not really helpful if there is a deficit to say where it is. Okay, so we have answered the first question with yes. Now we ask ourselves, could that be a problem of the peripheral nervous system? And the first criteria, and I will repeat that several times, if you have reduced motor function, meaning paresis or plegia in all 4 limbs, plus reduced segmental spinal reflexes in all 4 limbs, you have a disease of the peripheral nervous system. If you have reduced motor function in all limbs, plus reduced segmental spinal reflexes in all limbs, it's a peripheral nervous system disease. That was one criterion. The second one is a completely different one. The first one was all four limbs. The second one, if you have neurological deficits in only one limb, it's most likely the peripheral nervous system in that one limb. It's not compatible with the brain or spinal cord dysfunction. So if you have a patient that is turning around the paw, it doesn't matter front or rear limbs, and it's the only deficits you see are in this one limb, it's probably in the nerves of that one limb. Plexus brachialis tumor or avulsion typically does cause those deficits. Sometimes the patient is not standing that way, you have to perform actually your test, and you find deficits in only one limb, it's a peripheral nervous system. I have an example here. I'm not sure why he changed to that dot. So obviously there are major problems in the left rear limb. So is that peripheral nervous system disease? Yes. Maybe. Who said maybe? Why did you say maybe?
So, Neurological could be the reason for it, because there's no flexion, no extension, so tibial, fibular.
Yeah.
And we don't know exactly if the problem is in the spinal cord somehow. At the location where this neurosciatic was originating.
Yeah. I come back to that comment. If this dog would have a problem in only one limb, would we try to support it? Everybody has seen that a dog who has 3 healthy limbs can actually walk on 3 limbs. Now we could say, okay, we help it because it's not supposed to scuff with the nails, but we have not really done a neurological examination yet. We just believe to know that only one limb is affected. And I obviously did try to trick you by asking that question too early. So now we are testing the proprioception, that's the left side, the one limb he cannot use. Now the other rear limb. Oh, it's more than one limb. Yeah. We said peripheral nervous system disease if you find deficits only in one limb. You have to do your neurological examination. Yeah. And if you find deficits, even if they are very asymmetric, if you find deficits in more than one limb, it's not peripheral, most likely not peripheral nervous system disease. Yeah. So be careful by in making this judgment too early before you actually have done your neurological examination. If it is truly only one limb, then it's most likely peripheral nervous system. Let's come back to an example we had used before. I have a fox terrier here, and in this case it's really peripheral nervous system disease. The first thing I haven't mentioned yet is that most dogs with peripheral nervous system disease have normal mentation, normal brain function, because it's not affected. Yeah? They just cannot move. And if you see that here, there is some remaining voluntary motor function maybe in the front limbs, but it's plegia in the rear limbs. So reduced voluntary motor function in all 4 limbs. This dog could still have spinal cord disease. So we need more information. Conscious proprioception is lost. Actually, for a patient like that, it probably requires another person to hold it. Otherwise, you are not able to perform conscious proprioception. I mean, if the dog cannot get up, you have to support the weight. Maybe there's even tries to correct, but it doesn't work. It's reduced to absent. that could still be cervical spinal cord disease up to that point. That's not the dog, I'm just testing the muscle tension. Patellar tendon reflex, it's there. If it is normal, I don't know, but it's still there. Cranial tibial reflex, that's pretty good. Flexor reflex. Nothing. Is it just a matter that I'm not pressing hard enough, so if I don't get a response, I'm a little bit meaner? And you will see in a moment that the dog actually can feel that, but cannot flex. There is no flexor reflex in the rear limb. Let's see how it looks like again. That's me. Extensor carpi reflex. Could be normal, could be slightly reduced, I don't know. There's a little bit of gray zone if it's not, but flexor reflex. Nothing. And it looks exactly the same on the other side. If you have a patient like that, reduced to absent voluntary motor function in all four limbs and reduced segmental spinal reflexes in all four limbs, it does not mean that all reflexes have to be lost. You have to find a reduced reflex in any limb. Then it's peripheral nervous system disease. Why is that important? Because that dog does not need X-rays of the spine. This dog does not need CT of the spine or the brain. It even does not need an MRI. You will not find anything there because the problem is not in the central nervous system, it's in the peripheral nervous system. And since we are not talking about the peripheral nervous system later, I can tell you that the two most likely differential diagnoses for a dog like this are, now it's coming a complicated word, polyradiculoneuritis and botulism. And for both diseases, there's no real treatment. Basically, the disease basically has to run its course. You have to support the patient, to feed, maybe put in a urinary catheter, and you have to wait. And that's something you have to recognize just based on your neurological examination. That's actually not the patient you have to refer to somebody. Yeah. Because wherever you send it to, neurologists can do electrodiagnostics to confirm that there's a disease of the peripheral nervous system. And we can, in polyradiculoneuritis, sometimes we go the next step and we remove a nerve root, which is a quite invasive surgery, just to get the diagnosis of polyradiculoneuritis, which we already saw could be the case before. But you could actually wait. You have to inform the owner that not all of them recover, but the majority. Doesn't matter how bad they look like here. The majority of them may recover. A few cases of polyradiculoneuritis may not recover, and a few cases of botulism might be so severe that it interferes with respiratory muscles and they may die, but the majority just recovers by taking care for them and wait. Okay, peripheral nervous system disease. And I will explain you at the end why a patient with those symptoms cannot have spinal cord disease. I come back to that point.
Excuse me, Doctor.
Yeah.
Sorry. Regarding this botulism, Clostridium botulism, caused by the neurotoxins, correct?
Yeah.
Or is heat sensitive? Is the neurotoxins heat sensitive, or you keep the dog in the cool climate? Will it reduce the signs of the symptoms?
If we do what will, because of
botulism, Clostridium botulism,
yeah.
By the neurotoxin.
Yeah.
It's heat sensitive, correct?
Oh, heat sensitive, I understand. It's heat sensitive, but you cannot heat up the patient to a temperature where it becomes dangerous for the toxin.
Keep it off with a cool temperature, cool environment.
Oh,
it will reduce the problem of the neurotoxins.
I have never heard about something like that. I won't say that doesn't make sense, but I've never heard that anybody does that.
The toxins heat sensitive, correct?
Yeah, but it's heat sensitive. I saw to the higher temperatures. Yeah. But higher temperatures that are outside the range of the temperature of the mammal species. So it's important if you want to kill the bacteria or the toxin outside of the patient. But in my opinion, it doesn't help you. You cannot affect the botulism once you have it inside the body, as far as I know. And there's no antitoxin available, at least not to affordable price.
Can I ask, can myasthenia ever look like that?
Can myasthenia look like that? The short answer is no. The more complicated answer is that sometimes very severe types of myasthenia may actually cause reduced reflexes. Let's go one step back. The appearance, how the dog tried to walk, that can be myasthenia. But in theory, myasthenia does not reduce segmental spinal reflexes, at least if you test it once. However, having said that, there are rare cases where they can be reduced. They will not be lost as here, but they can be reduced. But as a general rule, myasthenia goes along with normal segmental spinal reflexes.
And the tick paralysis?
Sorry?
The tick paralysis.
Oh, sorry, I forgot tick paralysis, because it does not exist in Europe. I'm not sure how it is here. In Australia and in North America, they have a tick that causes exactly the same symptoms. And if you are the veterinarian who finds the tick and you remove the tick and 3 days later the dog is walking again, then you're the hero. Unfortunately, that does not exist for us. So for here, as I said, I can't say, but you said no, it does not exist here either.
Tick vector is not present in the
okay.
so far.
So, if you had your patient examined and you have been sure it's a neurological disease, but you say those criteria, at least the first two for peripheral nervous system disease, do not apply to my patient, then it's not here. And you go the next step. Actually, no, not the next step. Then let's go back to that. Sorry? I believe you should try to keep in mind those two first criteria, because if you apply those and one of them fits for your patient, you know it's a peripheral nervous system. But there's something underneath that is more gray than black and white. Some patients with peripheral nervous system disease have more vague symptoms, and that could be that they have exercise intolerance. They appear to be weak, and those patients are really tricky, because a weak patient can have nearly everything. Yeah? Muscle atrophy. If it is really going fast, if the owner is sure that the muscle atrophy happened within 1 week, that could be a hint that you are dealing with a peripheral nervous system disease. If it is more muscle atrophy over months, every animal that is not really walking around a whole lot because it's sick may get muscle atrophy, but fast muscle atrophy can help you. Interestingly enough, you can get with peripheral nervous system disease, and I have actually to say, if I say peripheral nervous system disease, we usually include the muscle as well, because it's a unit, a functional unit. And if you have generalized muscular disease, sometimes you may actually get hypertrophy, which does not make a whole sense, but it's a case. Some generalized muscular diseases may lead to muscle hypertrophy. So that would be another of those gray symptoms. If you have a patient that shows any of those symptoms, that's getting tricky. If you have a patient that shows that or that, it's easy to determine it's peripheral nervous system disease. One other thing that can help you is how the development of symptoms over time appears. Usually, many spinal cord diseases, especially disc disease, trauma, they suddenly start and they might be stable or they might get better over time. Neuromuscular disease, there are better days, some days are worse. As a tendency, the disease may progress, but it's not constant. If you have a structural disease of the spinal cord, it's there, and it will cause problems every single day. If you have a neuromuscular disease, the severity of the disease may actually be changing over days. And if the owner reports something like that, there is a little piece of information that may lead you maybe to neuromuscular disease. The way I look at my own work is usually like solving a puzzle. You get teeny tiny bits of information you put together. You will never get all pieces. If that puzzle has 500 pieces, at the very best you may get 200, 300, and at the end you have to guess what the problem is. But the more of those little pieces you are able to collect, the more likely you will come to your diagnosis. And the change of symptoms over time might be one of those pieces. I have already shown you that image before. If you have a spinal cord disease, and that really refers to spinal cord disease, independent from the underlying pathology, you lose your function in a certain order depending on the severity of the disease. If it is mild, it may just be pain or reduced paw positioning or conscious proprioception. If it is getting more severe, you get reduced or absent motor function. At the very end, you have your loss of deep pain sensation. Why am I showing that image when we talk about peripheral nervous system disease? If you have a patient that cannot walk anymore, just can't get up, you do your neurological examination and you find that that patient has normal conscious proprioception, then it's probably not spinal cord disease. Why? Going back to that image. If your spinal cord disease comes to the point that the patient cannot walk anymore, you should have lost your paw positioning before. So if you're already here, you cannot walk anymore, this function must have lost. Coming back to that image, to turn it around, if there is still conscious proprioception and the animal cannot walk anymore, it's probably not spinal cord disease. Does it make sense? Yeah? So either it's a generalized neuromuscular disease or it can even be bilateral orthopedic disease. And here I have summarized a few other symptoms of muscular disease. Weakness, we said, cannot walk. Bunny hopping gait. If an animal is weak and cannot walk because of muscular disease, you may sometimes see that they are not moving their limbs in a normal way, one after the other, but they try to hop like a bunny. Yeah? If you see that, cannot really get up, but tries to walk like a bunny, could be muscular disease. Yeah? Exercise intolerance, we had that. Ventroflexion of the neck, something we have not mentioned yet, more common in cats. They cannot lift up their neck. They walk around like that. And if they want to look up, since they cannot lift up the neck, they do something like that. They turn their neck to look up. But otherwise they walk around like that. Neuromuscular disease, very specific in cats. Megaesophagus. If you ask yourself if my patient could have neuromuscular, especially muscular disease, take a chest X-ray. The esophagus is only a muscle as well. And if this muscle becomes weak, you may just develop megaesophagus. So if I find in a patient who cannot really walk with some unspecific symptoms, if I find a megaesophagus in this patient, I would consider neuromuscular, especially muscular disease. This is lost. You get your titubation. You get what we call tremor, this sudden movements. Sometimes this tremor is only there if the patient is following and it has attention tremor. Whenever it tries to go with the nose to somewhere, it becomes most obvious. If it tries to sniff somewhere, you see this tremor, intention tremor. If this happens in a young cat, chronic, usually non-progressive, do you know what?
Can it be maybe linked with panleukopenia?
Exactly, that's the most likely diagnosis. Yeah? Intrauterine panleukopenia infection. For most of our cranial nerve testing. So if you have cranial nerve deficit, it often means brainstem disease. And then we have a specific group of neurons in the brainstem, the vestibular nuclei, and if they are affected, we may get vestibular disease. The vestibular syndrome, we will be talking about that separately, but quite often if we have brainstem disease, the first thing we see are vestibular symptoms. And why is that the case? And that's just my personal opinion. That's the case because the vestibular system is a very, very fine-tuned system. That's necessary, otherwise we could not walk around at all anymore. So if this very finely tuned system is affected by any disease, that's what we appreciate first. And that's why vestibular symptoms are often the first symptoms of vestibular syndrome. If we did go through our findings of neurological examination and say any of those fits, then we are done. If we did not find any of those deficits, then we have excluded the head. We only had excluded the peripheral nerves. The only thing that we are left with is a spinal cord. So if we are sure it's neurological disease, and that's something we have determined here, then we are looking at the spinal cord disease. And now we come to the last step. And the spinal cord we usually subdivide into 4 segments: blue, orange, green, and red. Obviously they are not blue, orange, green, and red, but those are segments. It's C1, C5, C62. Those are spinal cord segments. T3, L3, L4, S3. And we try to narrow down our neurolocalization to one of those 4 segments. And that is usually done, and now I'm coming back to your question, using the theory of the upper and lower motor neuron. Knowing that we have neurons sitting here where the swelling, the cervical swelling is, and here we have the lumbar swelling, here we have so-called lower motor neurons. Those nerve cells are here and innervating the limbs, or here and innervating the limbs. And then we have upper motor neurons sitting here, influencing the lower motor neurons. Whenever I try to teach that to any audience, I would say half an hour later, nobody knows anymore what I was saying. Yeah? That's not because the audience is not intelligent enough, it's because I'm just not able to present that topic in a way that it sticks to your mind. That's why I completely changed my way of presenting neurolocalization along the spinal cord, and I am not using those nasty words upper and lower motor neuron at all anymore. I skip that part. I usually recommend to answer 2 questions after your neurological examination in order to determine or to localize the problem to one of those 4 segments. And the first question is, after our neurological examination, do we have deficits in front and rear limbs? Or do we have deficits in the rear limbs only? If you answer that question, you have reduced your neurolocalization from 4 to 2. If a patient has only rear limb deficits, then the spinal cord from here to here has to be normal, otherwise the front limbs would be affected as well. So a patient who has spinal cord disease that is only affecting the rear limbs has a problem either in the T3, L3 or L4, S3 area. And the opposite applies in a patient that has spinal cord disease where front and rear limbs are affected. The problem has to be in that area, because if the problem would be here, the front limbs would be normal. Is that understandable? Yes. Yeah? So with this very easy question, you have reduced your 4 options to 2. Now the second question. Now we are looking at segmental spinal reflexes. And I intentionally say I am looking for reduced segmental spinal reflexes. And I hope I can explain that why. In order to explain how that applies to a patient, let's assume for a moment we are looking at a patient where the answer to the first question was front and rear limbs are affected. And we said in those patients it has to be C1, C5 or C62. Now I am interested in the segmental spinal reflexes in the front limbs. Those reflexes coming from the area of C62, that's where the swelling is, that's where the reflex comes from. If I test the reflex, it goes up here, response comes back. If I have a problem in that area, I want to find at least one reduced segmental spinal reflex. Or to turn it around, if I find one reduced segmental spinal reflex in that patient, the problem has to be at C62. If I do not find any reduced segmental spinal reflex in the front limbs, this area has to be healthy, and the problem is at C1, C5. And the same applies to the other situation, where we said the answer to our first question is only rear limbs are affected. In this case, everything here has to be normal. Only rear limbs are affected, it means T3-L3 or L4-S3. Now we are interested in the segmental spinal reflexes of the rear limbs. They come from that area. If I find at least one reduced segmental spinal reflex, the problem is here. Or if I do not find any reduced segmental spinal reflex, the problem is T3-L3. Have you heard me using the term upper and lower motor neuron? No. The theory behind what I've explained to you is still the theory of the upper and lower motor neuron. It's still the idea behind. But we don't have to talk about that. My opinion is just answer those two questions about neurolocalization along the spinal cord. What about increased reflexes? Yes, and now I have to use those bad words. Yeah? If we have a problem in this patient at T3-L3, we lose the inhibition of the upper motor neurons and you may get increased reflexes in the rear. However, I believe we do not need that information. If we have reduced reflexes, the problem is here. If we do not have reduced reflexes, and it doesn't matter if they are normal or increased, it's T3-L3. And I find it much easier to determine if a reflex is reduced than to determine if it is increased. That's why I recommend looking for reduced reflexes. And I don't care about increased reflexes anymore. I mean, I recognize them, but for neurolocalization, I would say look for reduced reflexes. Is that understandable for everybody?
I just have a question.
Yeah.
What if we have two lesions, one in the cervical area and in the rear area?
I call that the 95% neurolocalization. If you get lesions in different areas of the spinal cord, which is a very rare situation, but if you get different lesions, then it's indeed getting more complicated. Yeah? But it rarely happens that you get significant lesions in different areas. That's really the exception. Let's come back to Quincy. Quincy was the dog I had shown you with peripheral nervous system disease that could not walk at a probably nearly tetraplegia and reduced segmental spinal reflexes. I would like to explain why this dog does not have spinal cord disease. In order to do so, we have to pretend for a moment that this dog would have spinal cord disease. So what we will do together now, we will apply the neurolocalization of the spinal cord to this dog. Front and rear limbs are affected or only rear limbs? All four. Yeah? And that means it has to be C1, C5 or C62. Now this dog did have reduced flexor reflexes in the front limbs. That means the lesion is where? C62. Exactly. If this dog would have spinal cord disease. Now, for Quincy, if he has a lesion at C62, if this area is not affected, how should his reflexes in the rear limbs look like?
Segmental will be normal.
They should be normal. How did it look like in Quincy? He had to reduce flexor reflexes. In order to have spinal cord disease, and that's coming back to what you ask now, he would have to have a second lesion here. And that basically does not happen. You do not get significant spinal cord disease affecting those two areas at the same time. And that's why a dog that has, now I repeat it again, has significantly reduced voluntary motor function in all four limbs, plus reduced segmental spinal reflexes in all four limbs, has peripheral nervous system disease. Okay, I believe that's it. Yeah. Exceptions. That's what you said. There are exceptions all the time, but for the vast majority of patients, you will be able to localize it that way. It's break now, I heard. That's perfect, because it's my last slide. I'm probably already over the time, but then we can start after the break with some questions, if there are some questions left. Yeah? So then I would say you enjoy your coffee. Or tea. About the last talk, are there any? Yeah.
I just have some difficulties differentiating between tremors and shivering sometimes.
Me too. Difficulties differentiating between shivering and tremor. I would probably say that shivering has a little bit lower amplitude of movement. Tremor usually is a wider range. That's probably the only thing I can say. The other thing might be, if I have a tremor patient, then I look for other signs of cerebellar disease, and if I see them, then I am more convinced that I'm actually looking at tremor. Or we see sometimes tremor with certain types of intoxication. So if I know that this patient did have a specific intoxication, then I say, okay, I'm really looking at tremor. But the only medical or scientific difference is probably that shivering has a smaller amplitude than tremor. If there's no other question, then we just keep going with the next talk. And now we will be discussing certain groups of diseases, and we start with vestibular diseases. Actually, that's not entirely true. I will not really be talking about the diseases itself. I will focus on how to differentiate between what we call central vestibular disease, and I explain in a moment what that means, and peripheral vestibular disease, because for most of us, that's probably the decision: can I deal with the patient myself, or do I have to refer to somewhere else where the ability of advanced imaging doesn't exist? So that's why the focus is on differentiating between those conditions. Just to give you a number here, even though you might not be able to read that, that was a study, again, some students did a few years ago, and we did look at diseases we diagnosed in our hospital in the neurology service. So obviously you can see there is a large chunk here, that's intervertebral disc disease. And the question in this case is, how frequent is vestibular disease? And about 6% of our patients have vestibular problems. That does not sound like a whole lot, but it's number 4, just from the frequency. So in my opinion, that belongs to the more frequent presentations if one of our small animals has neurologic deficits, and it's quite often vestibular disease. Now, I already told you before that the vestibular system is very finely tuned. And that is important because if I bend over only a little bit, and if I would not detect and increase the strength of my muscles in my limbs, I would fall over. So it's very crucial that the vestibular system does already detect minor deviations from the upright position. And the question is, what do you believe? How many degrees do I have actually to bend until my vestibular system kicks in? Any guess? 5. Nobody else wants to say something. I guess 5 is already pretty good, yeah? But it's even less.
Any change, surely?
Yeah, I mean, people have tested that there's some degree, probably that's even beyond the ability to measure, then you could argue, but it's basically, you could translate that 0.5 in anything. Yeah, so probably very many, even before we think about, even before we realize it, the vestibular system is already kicking in. And that means if there is any disturbance of the vestibular system, we will recognize that right away because we get typical symptoms. And what are typical symptoms? On one hand, and we have seen other videos before, ataxia. And it has to be a generalized ataxia in order to fit with the vestibular disease. And it can be mild or it can be more severe. This dog has a more mild ataxia. And sometimes you only see that if the patient turns around or if the patient goes stairs. So now you could see it. Again, that requires that you allow your patient to walk around for a while. And you have to observe it. And it can even be less obvious than you see here. And sometimes it helps then if you instruct the owner to turn the patient in circles, basically to make it even more difficult for the patient. If you see that the patient then is crossing the limbs, something like that in any position, that's an abnormal position of limbs, that might already be a sign of mild ataxia. So ataxia is one symptoms we commonly see with vestibular disease. Another one, as I already told you before, is circling, and I said there are 2 types of circling. Vestibular lesions usually cause tight circles, small circles, where, as I said, if I move for quite a while and when I come to a point where I have to make a decision between left and right, then I turn to the other side. That's more forebrain. Vestibular circling, usually smaller circles. Head tilt. Head tilt is another thing that commonly goes along, usually to the side of the lesion. I believe the interesting part is that what we see here as abnormal in a patient with a unilateral vestibular disease is actually an appropriate response of the brain to abnormal input. What do I mean by that? Let's assume for a moment we have a normal patient. If we stand upright and if our head is upright, our brain gets input from both sides, from the ears, with the same rate and same frequency. And that's why the brain knows he is standing upright. If I turn now my head to the side, then the side that is down gives more frequent impulses to the brain. So more impulse from the right side means for the brain he is turning his head, and if there is no reason, the brain wants to redirect it, and I turn my head up to the side of less input. That's a normal situation. If I have now a patient...
And also how fast it's changed.
Also how fast.
Yes.
If I have a patient now that has lost one inner ear where the signal comes from, suddenly the brain does not get any input from this side. I probably should turn it around. I have to put it away. Let's say The brain does not get any input from my right side. For the brain, it gets more input from the left side now. And that means for the brain, he is actually bending his head. That's what the brain believes. But I do not. I am upright. But the brain wants to correct this bending, and that's why I am turning my head to the other side. That's a normal response of the brain to the wrong input from that side. Yeah? So I find it interesting that some things in neurology actually can be explained. Yeah? Yeah?
Doesn't that open up the opportunity of putting some sort of electrode that could actually compensate?
That's an interesting thought. Yeah, I've never heard that, but truly it could. At least for the head tilt, that could help. Maybe not for the other symptoms, but it's an interesting thought. Yeah. Thanks. Okay, so head tilt would be one other thing. And finally, and that's probably something we can recognize easily, is nystagmus. And I have a cat here with vestibular pathology. We will not see the ataxia because it's just sitting on the table. But I hope you can see that there's a rhythmic eye movement. And it usually has a slow and a fast phase. And we can keep in mind that the fast phase is usually going away from the diseased site. How can you memorize that? I mean, if you have any disease, you want to get away from it. You want to get away from it very fast. So the fast phase is going away from the diseased site in horizontal nystagmus. That's what we have here. And here we finally have a dog that is more or less showing all the symptoms I have listed before. The dog has a generalized ataxia. It may not be severe, but he is falling to the side. It's usually lateralized a little bit to the side where the lesion is. Has a head tilt to the right side. It has normal conscious proprioception. We will remember this a little bit later. And I believe we will see in a second that there's nystagmus as well. I believe you can already see now that there's nystagmus. Even though I'm trying to do the managed response, but there's nystagmus. So those are the symptoms, and we know it's vestibular disease. It's usually quite easy to recognize a patient with vestibular disease. It's not a mental challenge. It's one of the easier things in veterinary neurology. It's more difficult to determine where the problem is and what is actually the name of the disease. But to recognize vestibular disease is usually straightforward. One other symptom that is not as common, but it may exist, that patients may have a ventral strabismus. Sometimes it's ventrolateral strabism. And in some patients you may not see that as long as they are allowed to look straight, but if you lift up the head, the nystagmus may become obvious. So don't be disturbed by that. It's more commonly seen if the problem of the vestibular lesion is in the in the ear. I have not said that, but most of the patients we did look at before were patients with unilateral vestibular disease. So most of the symptoms we have seen are caused by asymmetric input to the brain. What happens now if you have a patient with bilateral vestibular disease? We obviously don't get circling anymore. We don't get head tilt anymore. And we may not have a nystagmus anymore because neither the left nor the right side is providing any input to the brain. All those symptoms are caused by asymmetric input to the brain. But if both sides do not report to the brain anymore, then we get other symptoms. We still have a generalized ataxia. We have some, I don't have a better term for that, some head swaying, some left and right searching head movement. And we may actually see vertical nystagmus instead of the other ones. And that's the way it could look like Usually the ataxia is more severe than a lateralized disease. Very uncoordinated, because nobody is telling this cat anymore where up and down, where left and right is. And we have those head excursions to the side. I will come back to this cat with the question, and you may already think about it. Is the problem of that cat more likely to be in both ears or in the brain itself? And we have to talk about that a little bit later. I already touched that topic that we differentiate between peripheral and between central vestibular disease. So peripheral means the inner ear. Central, there are certain areas in the brain, especially in the brainstem and in the cerebellum, and we will get a little bit more in detail. And both of them are connected by the 8th cranial nerve, the vestibular nerve. Actually, to be correct, it's a vestibular cochlear nerve. And then we have tracts that connect to the eyes and to the limbs. And as I said before, the main goal of my topic is to try to teach you how can I identify if a vestibular lesion is caused by inner ear disease or by central vestibular disease. I said if it is central, the problem can be in the brain, and that's the slide now that is more for those of you who are a little bit advanced. So I try to have more general information, and so for those of you who feel advanced, that it doesn't get boring, a little bit more detailed information that belongs in the second category. There are certain areas in the cerebellum, and they are very limited, that are associated with the vestibular system, and that is a so-called flocculonodular lobe. That's this little tiny thing here, the blue stuff here, plus the fastigial nucleus, and that's something right in the middle of the cerebellum, in the white matter of the cerebellum. If you look at MR images here, those white dots on the left and the right are the fastigial nuclei. That can be identified on MR images, at least the area where it's supposed to be. I said central, the problem is either in the brainstem, and on the last slide I said in the cerebellum. And there is still evidence that forebrain disease may cause cerebellar symptoms. Again, that's a little bit advanced level. There's a nice study that was published a few years ago, and for those of you who are dealing a little bit more with neurology, I probably should try to read that paper by Rita Concalves, because that's very nice. Infarction, thalamic infarction, and this little white dot here, that's an infarct. Maybe to go one step back, if you look at NR images, everybody does it on a daily basis, correct? No, you don't. But I'm pretty sure for those of you, at least for those of you who are a little bit younger than me, you will come to the point in your life where at least you have to understand a little bit of MRI. You may not believe yet, but it will come. So that's why, that's what we call a transverse view of the brain. And we differentiate on MRIs between the so-called T1 weighted images and T2 weighted images. I usually compare that with taking photographs. If you change the settings on your camera, you highlight different things in your picture. And that's pretty similar what is done on MRI. And we have two main settings, one we call T1, one we call T2. And it's nice if you are able to recognize if you're looking at a T2 weighted image or if you're looking at a T1 weighted image. And one way to recognize that is to look at a spot where you expect to be water. Because water is white in one of those sequences and it's black in others. And where is it white? Where is black? T2.
White.
There's a W. White. Yeah. So in T2 weighted images, fluid is white. Maybe that helps you. So I look at the brain, and there are the ventricles. They are very small in that patient. Here is the lateral ventricle, here is the third ventricle, it's white. So it's, what type of image? T2. Why is that important? Because most of the pathology in the brain goes along with some edema, fluid. And I have to know now, am I looking in my image for something abnormal white or dark? So on a T2 weighted image, I look for something that is white and that does not belong there. You may say, now, how do I know? I don't know anything about the brain. The brain is relatively symmetric. You can just compare the left and the right side. And if you look at that image and compare, usually we look at in the opposite way, that's the right side here and that's the left side, you easily recognize that there is some white that is not on the other side. So we could recognize that there's something wrong there, and we can say where it is. And that's now what I tell you. It's an infarct. It's a thalamic infarct. And we have learned over the years that thalamic infarcts can cause vestibular symptoms without really knowing how that works, because there are no vestibular structures there. But we know that's the way it is. And this paper describes nicely which symptoms. The basic question of vestibular neurology. Ear or brain? As I said, we recognize the vestibular symptoms, but we have to determine if it is brain disease in the localizations I explained you. But if you want, you can forget those localizations, but we have to differentiate between ear and brain disease, because that does influence our differential diagnosis. Those are obviously different ones if we have ear disease in comparison to brain disease. It influences the diagnostic tests, the prognosis, the costs. So that's why it's important right at the beginning, based on your neurological examination, to make that difference. Because it means, yeah, can I deal with the patient myself, or should I refer it to somewhere else? Because once we have determined it's central vestibular disease, you need imaging, advanced imaging, and MR much better than CT. I like to look at the diseases I am dealing with in this chart here. Here on the bottom it says how easy is it to treat a disease, and here how easy is it to diagnose a disease. So, and the size of this bubble refers to the number of patients we see. Obviously, intervertebral disc disease, it's a huge chunk, and it's pretty much on the right hand side and here on the top. So it's relatively easy to recognize and to treat, whereas a brain tumor, not as common, relatively easy to diagnose. If you have an MR, difficult to treat. If we put in vestibular diseases in this chart, and that's peripheral vestibular disease, and that's central vestibular disease. The first thing that becomes obvious, it's much more common. If you have a patient with vestibular disease, it's much more common to be a peripheral problem. It's less common to be a central problem. The other thing is that it's probably, especially for a general practitioner, because it's higher up here, it's easier to diagnose. And it's probably even easier to treat because we are further up here. It's much more difficult to diagnose and to treat central vestibular disease. So I like this chart to illustrate how difficult it is to deal with the patients we have. Now I will several times refer to this table, and that's probably, as I said before, I had one slide about neurolocalization. That's probably the one slide about differentiation between central and peripheral vestibular disease. I have different criteria here, and then I have listed how they behave in peripheral and in central vestibular disease. And the very first thing, if you look at those three lines here on the top, obviously if the brain is not affected, then we have a normal mentation, we have a normal behavior, and we have normal pore positioning, the conscious proprioception, everything is normal if the brain is not affected. Once the brain is affected, depending on where the localization of the lesion is exactly, all those can be abnormal. I can turn that sentence around again. If you find an abnormal mentation in a patient with vestibular disease, or if you find reduced conscious proprioception in a patient with vestibular disease, you more or less know that the underlying pathology is in the brain. And that's why I believe it's so important to perform conscious proprioception in the correct way. A patient with a vestibular disease barely knows where up and down is. And now you try to turn around one paw, and this dog is expected to do a correction. If you do not support that patient, it's virtually impossible to perform the test. So that's why support the patient in order to see if there's conscious proprioception or not. Nystagmus, the next line. You see that there are 3 different types of nystagmus here, and that refers to the direction: horizontal, rotatory, and vertical. And we will look at those. I'm going to jump that. Sorry. I come back to those slides. Let's start with a horizontal nystagmus. We have seen that cat before. Horizontal refers to the normal position of the eyes. So even if this cat is bending the head further, let's say 90 degrees to the normal position, even though it appears to be vertical, it's still a horizontal nystagmus. And that becomes important in a moment. So it refers to the normal axis of the eyes, if that is horizontal or not. That is horizontal nystagmus. Now we have an example of vertical nystagmus. It's really going up and down. I believe those two are relatively easy to recognize. It's more difficult to see a rotatory, where the eye is rotated along the long axis. Okay, we have to recognize those 3 types, because, now I go back to this slide, because vertical nystagmus is only seen with central vestibular disease. You could say, if you do vertical nystagmus in a patient, you can stop your neurological examination because you know that there's brain disease. Obviously, I cannot make that recommendation as a neurologist, because you have to perform a neurological examination all the time, a complete one. But basically, after recognizing vertical nystagmus, we know there's a problem in the brain. And if you do not take anything else back from this talk, then I would like at least to remember that vertical nystagmus means central vestibular disease. The problem is localized in the brain. Whereas horizontal and rotatory nystagmus can be seen with peripheral and with central disease. So if I see horizontal nystagmus, I do not know if it is central or peripheral. If I see rotatory nystagmus, I do not know if it is central or peripheral. But if I see vertical nystagmus, I am more or less done with my neurolocalization. I believe important, if we talk about nystagmus, is that I am referring here to what is called a jerk nystagmus. Jerk nystagmus, there is a fast and a slow phase. There are other types of nystagmus where the eyes are just having a more oscillating movement. That does not have to do anything with the vestibular system. So for vestibular nystagmus, it has to have a fast and a slow phase. And I come back to that. No, not yet. I'm not very organized. Here we have something where there is no fast and slow phase. That is something we commonly see in Persian cats and Himalayan cats, preferable with blue eyes. It does not have to do anything with the vestibular system. It's something that is wrongly wired in the optical system, it does not cause any problems. Those cats, or at least we believe, those cats are born with it and they die with it. The problem is that if you're not aware that this is not a vestibular problem, if you get a patient that is diseased, and you may actually be being the first person recognizing this nystagmus. Nobody has seen this maybe before in the cat. If you, by mistake, call it a vestibular disease, you make a huge mistake because you're on the completely wrong track. So if this is just oscillating, just ignore it. It doesn't have to do, it's not causing a problem for the cat. It doesn't have to do anything with the vestibular system. More or less just ignore it. Something else. Positional nystagmus. It's not here. Positional nystagmus. What does that mean? Nystagmus that either is seen only if you change the body position, or if the type of nystagmus does change if you change the body position. What do I mean by changing the body position? One easy way would be to lift up the head, and you may induce a nystagmus, or it may change the direction from, let's say, horizontal to rotatory. Or what is even worse is, and that's what we usually do, turning the animal on the back. If we see that, then it's more likely to be a central problem than a peripheral problem. It's not a black and white decision, but positional nystagmus is more likely seen with central vestibular disease. And that is something Leonardo is supposed to illustrate. Leonardo was presented to our hospital because he wasn't able to jump on his elevated seat anymore. And he was referred to our orthopedic surgeons because some hip problems were expected. The orthopedic surgeons didn't find anything, and the way it works in our hospital, if nobody finds anything, the patient comes to neurology because it's something fancy, crazy. There must be something wrong with the nervous system. So this cat actually did have quite some X-rays, and then it was seen by neurology, and we did our normal neurological examination. You can see there's no nystagmus. It was a pretty happy cat for us. He just doesn't know what's going on, why he has to look in the camera. And then we turned him on his back. And it's even vertical. Yeah? So just by turning him on his back, we knew that there's brain disease. Yeah? Everybody else could have done that before. Yeah? That's the MRI of Leonardo. For those of you again who are not familiar, that's a sagittal view now. So there's a nose, here's a spinal cord, that's the brain, forebrain, brainstem, cerebellum. Is
that arachnoid?
No, it's actually not. Ah, great. The first thing we want to determine is it T1 or T2 weighted? So if it is T2 weighted, fluid would be white. If it is T1, fluid would be black. So I look for an area where I expect normal fluid. And that would be here around that structure, that's the thalamus, that's the third ventricle. It's T1.
And fat white.
Yeah, but fat is white in all sequences. Yeah, that doesn't really help to differentiate. But what that tells us, that cannot be a cyst. Because if it would be a cyst, it would be black. Yeah? One type of information you are missing here, I haven't told you, that's T1 after giving contrast. So what we see there, white, is a huge brain tumor in the cerebellum.
Attenuation.
Yeah. So basically the entire area where the cerebellum was is replaced by a tumor, and there wasn't anything else to be seen in this cat. Then, when we turned him on his back, he had a nystagmus. What does that tell us about the tumor?
Slow.
It's very slow growing. Yeah. And that what usually happens with meningiomas in cats. They are very slow growing. I usually make that joke. I say if you are reborn and you can decide, the only thing I tell you, you have to be an animal with a brain tumor. Then decide to be a cat with a meningioma. Yeah? Because it's very slow growing. And there can be a surgery done in those cases. And usually those cats die from something else than the tumor because it will regrow, but it will be regrowing very slowly. Yeah. So we did actually surgery in Leonardo. Coming back to that image here, actually the cerebellum, where's the cerebellum? It's here and it's here. It's like a flower that opened up around the tumor. Now you can see a little bit like a cerebellum again after the surgery. And this cat lived another 3 years. He was already 11 when he came in. He lived another 3 years and died from some other disease. So meningioma in cat is something that can be treated. I don't want to be too optimistic. I usually tell my owners, you can die during brain surgery, yes. Or you can have additional neurological deficits, yes. But if you survive the surgery, if you do very well after the first 2-3 weeks, then you probably have a good life expectation. Yeah?
But technically that's not brain surgery.
Technically, because we are not doing surgery on the brain tissue, but on the tumor.
On the meninges.
On the meninges. Yes and no. In a cat, probably you are right. In a dog, I would say it's brain surgery because in a dog, meningiomas are obviously invasive, but it was a cat. You're right. Okay. So we did not do brain surgery in the cat. We did meningeal surgery.
Sorry.
No.
I like to keep our humors down.
No, everything is fine. You're totally right. Okay. Positional nystagmus, more likely to be central, but in Leonardo it was even vertical. It doesn't matter that we had to turn him around in order to see the vertical nystagmus. If you see vertical nystagmus, it's central disease. Yeah. So we did talk about that. So there were some other criteria in order to differentiate cranial nerve deficits. As you can see here, with ear disease, only one of the cranial nerves can be affected. The facial nerve. You can get on that side facial nerve paralysis. Whereas if your problem is in the brain, multiple cranial nerves can be affected. Why is it that the facial nerve can be affected? I will tell you in a moment. Just to start with the symptoms. The facial nerve, as I said, is the one that is responsible for everything we do with our face. Yeah? So you get a paralysis on one side. You see this droopy lip. We see a loss of manners response because I cannot close my eye anymore if the hand is coming. Loss of palpebral reflex, all that is lost. Some owners don't recognize that. They come in and tell you the animal is drooling. The saliva is coming out of the mouth on one side continuously. Yeah, because it cannot close the side here in order to prevent the saliva from drooling. The facial nerve travels through the wall of the middle ear. So if you have ear disease that is severe enough, it may actually affect the facial nerve. And here's the image to illustrate that. That's a computer tomographic image. Here is an MRI. It's a transverse image. Here we have cerebrospinal fluid on the top. That's why it's a T2 weighted image. Fluid is white. And what we can see on this side, this radiolucent line here, that's the facial canal. We do not really see the facial nerve on CT images, but here is the facial canal, here is the inner ear, here is the middle ear. So if you get a disease in that area, it may well affect the facial nerve as well, because it's really in close proximity. MR is even a little bit better in the sense that we can see the facial nerve, at least I can see it. This teeny tiny line here, that's the facial nerve. Here we have the inner ear. Here we have the middle ear. The middle ear is normally air-filled, and that's black on a MR image. The fact that we have white here means that there is a filling of the middle ear. So we have middle ear pathology, and that can affect the inner ear and the facial nerve as well. And that's why you may see facial nerve and only facial nerve pathology of all the 12 cranial.